Redesign. And welcome everybody. And I have started recording so we can record this. It is July 21st. And Heather, do you want to go to the next slide?
Sure will.
Thank you.
I think. Maybe. Or not. One second, and let's see if I can get this.
Well, thank you, Heather.
Did I get it?
Yeah, you did.
Okay, perfect.
So just a couple of things about this morning's webinar. We're having a couple of technological issues, so we apologize. It's going to be recorded. It is recording, and it will be posted to our YouTube channel. And there will be links to that sent to you all if you already haven't received them. Some of you probably received them, maybe some of you haven't. So I will make sure that everybody has those links. All participants are muted and off camera for the entirety of the webinar, and we will not be accepting questions via our chat or Q&A on the WebEx. We are accepting questions via our Microsoft form, which you can see the link here, as well as the QR code for that form. And it should be live as we speak. So as we are going throughout the presentation, if you have questions, feel free to put those in the Microsoft form. We will not be answering those questions during the webinar. We have a lot of content to get through, but we know that there will be questions, and those are important to us. We will be developing an FAQ to go up on our website, and those questions that you all submit will be informing that FAQ to help us format that FAQ. So we appreciate any questions that you all have. So I think that's it for this slide. Let's go to the next slide. All right, I am going to welcome our Behavioral Health Division Director here at DMAS, Lisa Jobe Shields. She's going to do the first part of our webinar this morning. And here in solidarity, as well as many other aspects of helping us, is the Deputy Commissioner of Community Services at the Department of Behavioral Health and Developmental Services, Heather Norton. She and her team have been instrumental in helping us plan for behavioral health redesign over the past year, and we're very thankful for their input. I also want to shout out the Department of Health Professions, who has also been very helpful and our key partner in this project over the past year. So thank you to them as well. Next slide. All right, today's agenda, we're going to go over project overview. We're going to talk about what we've done over the past 6 months in terms of planning. Then we're going to talk about the new service array, so the actual services that are going to replace our old CMHRS services. We'll talk about the rate study assumptions, and then also let you know what the rates are, which is the exciting part. And then we're going to talk about what next steps are, including a provider readiness survey and what our training plan is. We are very steeped in planning for pretty much everything around this project, but a training plan training plan of providers is key to making this work, and very important. So we'll be going into depth on what that's going to look like, at least at this point. So that's what we're going to talk about today. And I am going to hand it over to Dr. Jobe Shields. Welcome this morning, and take it away.
Thank you, Laura. So hi, everybody. Thank you so much for joining us. We're really excited to provide this update today. A lot of you have been supporting this work over the last year, so you've seen parts of this, but hopefully today's webinar will give a good picture of kind of all the different pieces and how they've come together thus far as we're closing out the first year of the project, getting ready to start the second year. So this is our overview. This hasn't changed in the last year, but when we try to sum up this project, The goal is really to work together across DMAS, DBHDS, DHP, and our managed care health plans to address the rate, the service definitions, and the provider roles for our Medicaid legacy mental health rehabilitative services. The services being redesigned are intensive in-home, therapeutic day treatment, mental health skill building, psychosocial rehab, and mental health case management. The budget authority that this project is being implemented under allows us to move forward with budget neutral changes identified through this rate study that I'll be sharing the results of today. And the idea is that they must be replaced with evidence-based trauma-informed services. Next slide. So early in the project, we set these 4 priorities, and hopefully these are priorities that you all saw earlier in the process as you were completing the surveys for us and giving us input at all the different sessions. These haven't changed either. Number 1, we're just trying to generally strengthen the evidence-based trauma-informed continuum. Our services hadn't been fully updated since really when they were written. So they had a lot of it sort of from the mid-90s era. And so there's just been a lot of things that we've learned about best practice that deserve a place in our service definitions. So really just kind of these general updates. Our next priority is trying to promote earlier intervention to the extent possible. These are and will remain our rehabilitative services. So they're providing rehabilitative treatment for mental illness for children and adults, but we still think that we can do better in terms of catching people earlier and giving them access to the services that they need earlier in the disease course, because this really has been the primary scientific breakthrough of the last 20 years with mental illness. Really the idea that it's that duration of untreated mental illness at onset that is that primary predictor of those long-term outcomes. So we think that we can do better and get in a little bit earlier by designing our services in a tiered way. Our third priority is designing them for the managed care delivery system. So these were all written prior to behavioral health services getting carved into managed care health plans in Virginia. And so, because of that, they really weren't written in a way to make those processes run as smooth as possible. So we're really excited about updating them in that way. And we also want to integrate our workforce priorities. So as part of Governor Youngkin's Right Help Right Now plan and just the more broad response to the behavioral health workforce crisis, we want to do whatever we can to align. And there's new professions that are being introduced in Virginia. So we've done our best to try to integrate those into the new services. Next slide. So again, just general overview. This is a 2-year project. This webinar really represents the end of year 1 and going into year 2. It's July 21st, so we feel pretty good about this. Our goal was always to have year 1, so as of July 1, focused on research, stakeholder input, completing the rate study and completing the fiscal impact study. We're a couple weeks out in getting it public, but we feel overall that we are still on track. And because we've also been doing a lot of year 2 planning. But year 2 is going to focus on implementation. So all of the services that we described today, year 2 will be about defining them in an even more specific way, getting really operational in terms of what are these going to look like, what's the transition plan, how are we going to implement these in managed care, making sure that everything is ready to go before July 1st of next year, 2026, when these changes will go into effect. Next slide. So in terms of the updates and where things have been for the last 6 months, so hopefully some of you were able to attend our last webinar, which was in December, and that was when we put out a draft of the community psychiatric support and treatment definitions. We got a lot of great feedback and have been working with that feedback to then essentially complete the rate study and complete the fiscal impact study. So there's some of the milestones that we've hit along the way. The rates were set first. You'll see in a second what we set rates for. And then the fiscal impact study was completed to figure out what we can implement July 1st, 2026 that would be considered budget neutral. And then here we are, July 2025, trying to move into phase 2, which we're calling implementation. Next slide. All right. So when we were putting together the rate study, we were tasked with ensuring that we were going to have an evidence-based trauma-informed continuum. But then of course, the rate study, we had to design the study to a certain extent so that we could bring on our contractor, who's Mercer, who did the study for us. So these are what we put into the rate study. This is what we asked for rates to be set for. We needed a general rehabilitative service structure. We needed it to be for adults and youth and for school settings. We wanted them to look at some of these specific evidence-based practices, such as the clubhouse model, such as coordinated specialty care. And then we wanted them to look at a level of need model and an assessment. We also had them look at some things that we knew might be a little further down the road or wouldn't be budget neutral, but we weren't sure because it obviously all depends on the physical impact study. But we had them study a number of specialty clinical approaches that could be done in outpatient or in CPST, such as parent-child interaction therapy, supported employment, the pre and post tenancy supports that go along with permanent supportive housing, and high fidelity wraparound. We also had them look at a few adult residential services, but we're not going to be presenting on those today because it was where the timeline was with when we were designing the 1115 serious mental illness waiver. So overall, they looked at a lot and developed actuarially sound rates for a lot of things. But we did know from the beginning that we wouldn't be able to implement all of these, July 1, 2026. You can go ahead. All right, and so for the services that we are implementing, Laura, as we go through each service, Laura will be sharing the high-level details for those rate assumptions specifically. But I wanted to give just some very general information because, in behavioral health, a lot of our rates and what we need to reimburse for services, a lot of it really is those personnel costs. We're paying for people's time to spend time and do interventions with our members. So these are just, again, some of the factors that we had to consider, and Mercer talked through with our finance team, looked at how we've done it in other rates in the past, and made assumptions about all of these things. And so some of these you'll see when we do the specifics. Some of them, like transportation, we kind of put the same thing in each rate. Other ones, there is some variability based on the feedback that we got in the survey and different things like that. So again, we won't do this for all of the rates that were developed, but as we talk through each rate that we're going to implement, Laura will share some of those high-level details with you about what went into that rate specifically. But this is just kind of some of the general information, and also some of the information about all those surveys that you all completed. We did have 127 of those in-depth surveys completed, so we really appreciate that. We also had 42 representatives from school districts complete a separate survey so we could better understand their perception on TDT and school-related mental health needs. And we also had 80 members complete surveys in addition to the 11 listening sessions that were held. And so essentially with the rate study, we did a balance of when there was Virginia-specific data that we felt was reliable, we used that. And then when there wasn't, or there was a reason to think that national data would be better, we used the national data that Mercer was able to share with us. So you can go ahead. All right, so starting to kind of move a little bit more into the results of the study, I want to start with this slide, which is comparing our behavioral health spending in 2018 versus 2024. And so as you can see, behavioral health spending has overall increased significantly from 2018. But when it comes to sort of what has increased, it's not necessarily these rehabilitative services that we're redesigning at this time. So number one, a really large change from 2018 to 2024 is the numbers served. So thinking about Medicaid expansion and other types of program expansions, we went from around 200,000 people being served with our behavioral health services to about 350,000 people being served. As you can see, the price per person also went down. So we can infer from that a lot of this that we're talking about is more access to early services like outpatient therapy and things like that, because ultimately our per person cost is going down and we're serving a lot more people. A lot of the increases that you do see between the two, again, they're not in these rehabilitative services. even though they are in the sort of that umbrella of our state plan. So things like crisis and applied behavior analysis, services that are kind of all part of this benefit in general, but not these actual community mental health rehabilitative services. And those services, so the kind of that red bar, our spending on mental health rehabilitative services specifically has actually gone down by 40% since 2018. And so I think this is something that, the state has felt. There's a lot of the COVID impacts in there, a lot of the transition issues of different systems changes that have happened since then. But it has been a significant decrease in spending since 2018, which is around when a lot of these conversations started about redesigning these services and how we could use these dollars to meet the needs of our members. You can go ahead to the next slide. All right. So that brings us to sort of, what was the fiscal impact study? What were we comparing? How did we define that within the budget language? So like I said, it has been, the spending has gone down by 40%. So what we did with this current language is we took the current spend in community mental health rehabilitative services and projected it to 2027. And essentially what that got us to is $556 million in spending. So that's really our target number here. As you can see, one aspect that was a little bit unexpected, even though maybe, once it came out, I guess we weren't really as surprised as maybe we could have been, that ultimately Mercer found through the study that our youth mental health system was underfunded compared to our adults. And that means like a lot of different things. I mean, obviously you can tell just by looking at these general numbers, the discrepancy, but also it came down to the dollar for dollar rates. So when it comes to what we were paying for mental health skill building versus intensive in-home, sort of unit for unit, dollar for dollar, we were not paying on the youth side the same as we were on the adult side. And this is really important for a number of reasons, just in terms of setting expectations and thinking forward, because as you might know, the federal government matches the state funds differently for children versus adults. So again, it all sort of in the math behind the budget neutrality. But this is our target. The idea is that there's, in a budget neutral scenario, there's about $556 million that will be being spent on these services. So that's the amount of money that we're working with to define the new services on an annual basis. All right, go ahead. All right, so when it came to doing the fiscal impact study, so again, we did the rates first. And for just the services that we're implementing, Laura will tell you some of the details that went into those rates. But when it came to figuring out what could we implement, Mercer did that. That's essentially the part of the study called the fiscal impact study. And they did two approaches. So the first one is what we've been calling the one-to-one approach, which essentially took the new rates that we had developed and then applied them to current utilization. So what's currently being billed now, if it were to be billed at the new rate, specifically for the community psychiatric support and treatment, what would that look like? And then for the newer practices that we don't necessarily see billed currently in Medicaid, at the proposed unit rate, what would those cost? So that was kind of the one-to-one approach. And as I tell you the results of that in a moment, you'll see sort of why we did ultimately need to do the whole fiscal impact study based on a more level of need approach, which certainly was the plan, again, with the tiered service design, that was certainly the plan for implementation. But we had to define a lot of that during the fiscal impact study so that we could, make it clear about what we were authorized to move forward with and without. So I'll be sharing a lot of details about that in the coming slides. You can go ahead to the next one. All right. So as you all know, the units of our current services are, they're kind of different, right? So one example is with mental health skill building. One unit build could represent anywhere from 1 to 2.99 hours of service. And so we really don't actually have a lot of information on the face-to-face time that are happening during like a typical session where you're going out. We just know they're these very broad ranges, and this is one thing that stuck out to us as something that most states don't have billing structures like this anymore. But to just sort of start the study, we took the lowest end. So we said, okay, if one unit is 1 hour, then that would be 4 15-minute intervals. What would that look like? So that's where we started. And just looking at the community psychiatric support and treatment service, the estimated spending was already about 147 million over the baseline spending. So essentially what that means is in the new services, again, we can't exactly compare apples to apples because we don't know how much face time is currently being spent. But overall, the new approach and the new rates is going to need to be a more focused treatment approach. So the time spent will be likely less face-to-face time. Again, we're not exactly sure because we don't have an exact measure of the current face-to-face time, but just looking even at the 1 unit equals 1 hour, that's essentially one of the big take homes in terms of the difference between the current services and how much face time you could potentially spend within a billing unit versus how much will be expected in the future. You can go on to the next slide. So these are those intervals. Again, I know that we haven't shared with you the details of the service yet, but again, we'll be saying this sort of a lot of different ways because it is one of the primary changes. So I'm kind of sharing it with you in this format now, but once Laura really describes the services themselves, I think it'll all kind of come together. But I did just wanted to share it on the front end as well before you hear Laura's content, just again, because these are just complicated changes. So wanted to, just kind of reiterate it a few times. So essentially this is just our draft level of need model. This is not final in any way, but this is the direction that we're going in. And essentially the idea is that community psychiatric support and treatment would be authorized in 2 tiers. We're just calling it CPST Tier 1 and Tier 2 for now. And so Tier 2 is the one that will more directly mimic our current services. But even that, again, it's going to be likely less face-to-face time than current. So you can see here the maximums that we're considering for that Tier 2 replacement service, which is an intensive service, more similar to our current services. It'll be looking at between 20 and 28 hours per month based on the need. So you can see we're just showing this just to illustrate it. Per week, that would be like between 4 and 7 hours, for example. So that's kind of what that core intensive replacement service will look like. And again, this could be less face-to-face time than a lot of folks are currently providing. So that's our Tier 2 CPST kind of framework. Again, all the details of the service itself, Laura will be sharing. But since this is how we had to actually do the physical impact study, I just wanted to share some of it up front. So that's kind of the Tier 2, again, the more direct replacement. And then Tier 1 is the new service that we're considering to have a lower bar of entry. Again, not a preventative service. It still needs to be rehabilitative to treat a condition that's been diagnosed. But we're hoping that this can get people in earlier and have a better bridge between sort of like outpatient therapy that you might be going to once or twice a month versus our very intensive community-based services. So where this one landed is essentially it's between like 4 and 9 hours per month. So it could be, 3 hours per month, 7 hours per month, really up to 9 is where the estimates for Tier 1 are coming from. So again, when you think about that during the week, it's essentially 1 or 2 sessions per week. So this is definitely a lower touch service than our current services. But that really was the goal to set something that is a little bit more intensive and that could fill that gap between outpatient and the intensive service. So again, I know this is like really complicated and we'll be saying this a number of different ways, but ultimately for this base replacement service, it'll be authorized as tier 1 or tier 2, with tier 2 looking like 20 to 28 hours per month and tier 1 looking like anywhere from 4 to 9 hours per month. You can go ahead. I think, yeah, that I will stop there. You can actually go back just for 1 second. I'm sorry, Heather. Just to show you all where we'll ultimately be going. Today we're just focusing on the new services being implemented, but you can see that the general idea is that we will ultimately have a level of care model that integrates all of our existing services and our new services. So for example, you can see at these higher levels of need, 4, 5, and 6, assertive community treatment would be appropriate potentially, but if they don't meet criteria for that, that's when they would be referred to CPST tier 2 services. So ultimately our goal is to have an organized level of need model that describes our existing services, our new services, including the tiers of the services. All right, you can go ahead, Heather. Thank you. All right. And so this is our, essentially what we're calling our final budget neutral model. And so the rest of the webinar is going to focus in on these specific services. So the services that will, we're still planning and on track per the budget language to retire July 1st, 2026. It's intensive in-home, therapeutic day treatment, mental health skill building, and psychosocial rehab. Case management, we are still going to use the same billing code and likely the name will be the same. There's going to be changes to the design and some tiering, but when it comes to actually retiring the billing codes and bringing new ones online, those will be more service changes, whereas these 4 service codes will no longer be billable as of next July. And the services that we will have in place of them are those on the right side. So number 1, we will have a standalone assessment. And so this is for the level of need placement. So we'll talk about this throughout the webinar, both in terms of the service itself and the training needs. So I won't give too many details here. But again, that will be a standalone replacement service where there will be a separate billing unit and billing structure for the assessment. There will be this new large rehabilitative replacement structure, which we call CPST. We didn't come up with this. This is actually just the generic name of the actual like CPT code that's used nationally. So it's just a common name that people use, but yeah, it's actually just the generic the generic name. We do have the flexibility to kind of give it a little bit more of a Virginia name, but this will be the billing code. And so for now, we're just kind of going with that generic name, CPST. This will be billable in the community for youth and adults, and then as well as with school-specific structures for youth. And it will be authorized again as tier 1 or tier 2. Also, we will be bringing on coordinated specialty care for first episode psychosis. So this is a wraparound evidence-based practice that DBHDS has been working to stand up in Virginia for many years. But currently there is not a sustainable Medicaid-specific rate in Virginia. So we will be bringing this online through Redesign as well. And then the final one is a specific evidence-based model of psychosocial rehabilitation. This is the Clubhouse International model. Many of you might know of the general sort of Clubhouse model to some of our current PSR programs. This is in reference to the same thing. But it's a model that actually sort of predated our PSR programs. Our PSR programs over time, because of Medicaid, have become more clinical in nature. That's kind of how CMS was requiring things in the 90s and the early 2000s. But now that the evidence has really kind of clarified around all these processes, we actually know that a longer term sort of maintenance type service with a strong employment focus, which is the Clubhouse International model, that's actually sort of a really important part of an evidence-based continuum. So we're really excited to be bringing all of this on. Again, it's a standardized assessment. It's a general replacement service that's for adults, youth, community, and schools, and we'll have 2 tiers. Coordinated specialty care for first episode psychosis, which is a a wraparound evidence-based practice, and the Clubhouse International model of psychosocial rehabilitation. All right, next slide. Now, I think, Laura, I'm not going to pass it to you at this point, but we're also not going to go into the details here again, because there's a lot of information to share. And Laura is going to be telling you about the services, but these are just to kind of show you where the rates ended, where the rates landed. This is where they are. You will be generally billing based on provider type. So you can see there's a different rate for when the licensed mental health professional is interacting, when the qualified mental health professional is interacting, and when the new profession, the behavioral health tech, is interacting. These are all going to be 15-minute intervals, and you can see in the blue column there what the rates are. The individual rates are here on the left, and then the group rates, which just represent a 4-person group assumption for youth and a 6-person group assumption for adults. Those would be the rates that you would bill for a single individual getting a group-based service. And they're just, you can see they're just kind of the simple math versions of that, just the 15-minute interval for an individual divided up among group members. So again, lots more details here as you hear more about the service. But again, the real take home here is we were able to set a rate for all 3 professional types within the range that Mercer recommended. We weren't, you can see here, we were not able to set rates at the top of the range. They're much more slightly below the midpoint, but they're rates that we feel good about, and you can see by looking at them, and you can see the kind of the full ranges of what Mercer said would make sense. And then where we landed in the budget neutral rates that we're going to be implementing. So again, the blue ones are the final rates. Just wanted to show you the Mercer ranges as well, so that you can see, again, not able to, put things at the very top of the range, but where these are is a little bit really below the medium piece of the Mercer range, I guess is the best way to say it. All right, next slide. These are the non-CPST rates. So for Clubhouse International model, it'll be paid on a per diem, and that it's a $72, approximately $72 per diem. The coordinated specialty care for first episode psychosis. Sorry, that's my background noise here. If this turns into a fire alarm test, I might need you to jump in, Lara. But so for coordinated specialty care, there's a national. Can you guys hear me, Lara, or no? You can hear me, okay?
We can hear you. Yeah.
Okay, just jump in if something loud happens. So for coordinated specialty care, this is actually a national model that they've been pushing. They're actually pushing this in private insurance as well. And what it is it's a monthly case rate. And then there's also an encounter rate that essentially, so with this treatment, Laura will go into the details. Oftentimes people receive about 2 years of the intensive treatment, and that would be billed at the monthly rate. And then after, 2.5 years, you would start to taper off. And then once you're kind of not hitting, whatever the required units are for the monthly rate, you would start billing an encounter rate to kind of step them down into whatever lower level service they were going to be getting after that. Mental health case management, this is going to remain a monthly case rate. You can see there the Mercer range and where we set it, transparently, it's not much different than our current rate, but it is slightly different. So it's $374 per month per individual. And then when it comes to the standardized assessment, it's going to be a unit rate. Again, so this will be a little different than, it's not the 15-minute intervals that'll be billed for CPST more broadly. It's our assumption is that it's going to be about 90 minutes of time with a licensed person and about 90 minutes of time with someone such as a QMHP who's going to be working directly with the client, and that it would essentially, you would bill these for about 90 minutes each, which comes out to a $323 unit rate. if that makes sense. I might not have explained that one so well. But again, it's a unit rate. It's $323. And the way you're kind of constructing that is through about 90 minutes of time with a licensed person. Again, this is gonna be like the diagnostic interview and things like that. And then 90 minutes of time with the qualified mental health professional or the non-licensed member of the team. All right, next slide. All right, so this is kind of my summary slide before I pass it to Laura. Again, the rate study was completed. There were 11 potential replacement services. There was a couple of other services that we looked at, as 14 total, but there were 11 kind of potential replacements, and we have rates developed for all of those. Because of this sort of general decrease in rehabilitative spending, as well as the differential between the child and the adult system, our budget neutral target was $556 million for projected state fiscal year 2027 spending. And we do have an implementation plan that, again, we don't feel that it's going to, it's not yet a full continuum, but we feel that it's a strong replacement plan for the legacy services that we have to retire next July. And what that is it's a core service, which we call CPST. It'll be authorized at 2 different tiers, tier 1, tier 2. It can be provided to adults or youth in the community or in schools, as well as 2 specific models of evidence-based practices that are more standalone. So the Clubhouse model and CSC. And the assessment. Perfect timing to pass it to Laura.
Awesome. Thank you, Lisa, and have fun in your fire drill. All right. Thanks, Heather, for moving the slides forward. We're going to talk a little bit more about the specific services, some draft service descriptions, and a little bit about the actual rate assumptions that went into each service. It's not going to be a complete overview of each assumption because that would take many, many hours, but it will be the high points of things that are the most important. So you can go to the next slide. So just to kick off this discussion about our services, it's important to understand how Medicaid defines our behavioral health services. We define them, really this is at the federal level, as a rehabilitative service. And to really understand what that means, a rehabilitative behavioral health service means assisting individuals regain skills or functions that they have lost due to a mental illness or a substance use disorder, or a combination of both. Or they're compensating for impairments due to a disorder. This really is these loss of functions and compensation really start between the time and entry into treatment and some sort of developmental stage, age of onset, trauma exposure, or support system. There are a lot of things that go into determining when that stage happens in terms of untreated mental illness. And then our services hopefully really look at those domains, and it really means closing the gap between that untreated mental illness time and the time that they are provided services by one of our providers. And the attempt is to recover and close that gap. So that's really the purpose of our services. All our behavioral health services are considered rehabilitative. And we can go to the next slide. This is really a restatement of what Lisa already said, but I think it's good to talk about it. We're going to talk about it probably many, many times, and you'll hear it many, many times over the next year. But just as a crosswalk, a reminder of sort of where we are right now and what services are going to replace our current CMHRS services. So mental health skill building and psychosocial rehabilitation will be retired. on June 30th of 2026. And the replacement services for those services are not a one-to-one relationship. There's a combination of services depending on what the individual's treatment needs may be. And so the replacement services for those two programs are community psychiatric support and treatment, community-based, coordinated specialty care, and/or clubhouse model of psychosocial rehabilitation. For intensive in-home, which will also be retired on June 30th of 2026, the one-to-one relationship in terms of replacement will be community psychiatric support and treatment, community-based. Therapeutic day treatment, which will also be retired on June 30th of 2026, will be CPST. The replacement will be CPST, the school setting service. And for mental health case management, as Lisa stated, mental health case management will not be retiring. There will be some updates to the service and some policy changes that we'll be implementing over the next year in collaboration with the CSBs. You can go to the next slide. So let's talk about community psychiatric support and treatment. That's really what is going to be replacing many of our services. And we're going to talk about, and these are draft, so these are draft policies. Nothing has been finalized as of yet. We're hoping for an informal public comment sometime in the September, October timeframe. And then certainly the policies will go up for formal public comment at some point, most likely in the winter, as we work with CMS to get our state plan amendment approved. So these are agency level requirements. Again, these are draft requirements. A provider may offer community-based CPST and/or school setting CPST. You can offer it to either youth, adult, or both. This will be a provider choice. Providers may offer community home-based, or they can do school setting. The school setting is only for youth. There is no center-based CPST for adults. The Clubhouse International Model of Psychosocial Rehabilitation will be the center-based for our adult SMI population. For CPST, there must be a full-time clinical director that is an independently licensed mental health professional that provides clinical oversight of all CPST services. There will be supervision requirements, including hours of supervision and other requirements for licensed, eligible, licensed, and non-licensed staff. There will be caseload limits for each staff level, licensed, unlicensed, including across agencies. So we know that there are individuals who work at more than one agency. So there will be caseload limits, a total caseload limit across all agencies in which that individual works. Evidence-based practices and principles integrated into the service definition where possible and through statewide training, which we'll talk about a little later in the presentation, will be required for all providers. And additional evidence-based practices are recommended. The provider must be accredited by one of the four nonprofit entities that you see on the screen: CARF, COA, DNV, or the Joint Commission. And that is required within approximately 2 years of being licensed and enrolled as a CPST provider. You can go to the next slide. So this is getting into a little more detail about our service components. Many of you are already aware of what our current service components look like in our current CMHRS services. So those services look like the comprehensive needs assessment, treatment planning, crisis intervention, skills restoration, care coordination, and counseling. The new service components, which will be replacing those, will be, Lisa already spoke about it, a standardized comprehensive assessment of needs and strengths, and we will be calling that CANS Lifetime. That will be something that all providers will need to be trained in, and will be connected to our level of need model. Treatment planning, of course, is the same. Crisis support is going to be a little bit different, and we'll get to that in a little later slide. But certainly the supports that are provided in intensive and home that are currently provided, it will be similar for CPST. and providers will need to be on call 24/7. Restorative life skills is a new service component, and that will be provided by, generally speaking, an unlicensed staff member. Care coordination, psychotherapy, health literacy counseling, which is education around medications and medication regimens, and rehabilitative skills practice is a new service component and only in Tier 2 of CPST and provided by an unlicensed staff person. You can go to the next slide. So this is just a crosswalk around, again, what our old services look like and what the new service components look like. And so what was already there and sort of what wasn't there and what we're adding. And so the red is really, obviously all of our services required the comprehensive needs assessment. That will be, the reason it's in red is because it will be changing to now CPST will require our standardized assessment. So everybody will be trained in our evidence-based standardized assessment that connects to our level of need model. And all of our licensed clinicians will need to be trained and how to perform that assessment and complete that assessment. So that is what is new. Treatment planning, of course, will be similar to what you all do now and will be included. We have 2 services, intensive in-home therapeutic day treatment that included psychotherapy, but mental health skill building did not. So that will be the difference with CPST for adults. That psychotherapy will be included in the service. The same for crisis supports. So there are crisis intervention and crisis supports and intensive in-home and a therapeutic day treatment, but not currently in mental health skill building. So that will be a change for our adult providers to be required to provide crisis supports within the CPST service. Care coordination is across the board, so that shouldn't be new. Restorative life skills training, which is really about skill building, and it's just sort of a change in how we name the actual service component. So skill building was in mental health skill building, not so much in intensive in-home, even though I know that providers do skill building intensive in-home, but not really so much in our service description. And then of course, skill building was in therapeutic day treatment. So that will be a big portion of what CPST providers do. Health literacy counseling was not in any of them, so that will be new to CPST and providers. And then rehabilitative skills practice, which is only Tier 2. Again, this is really about practicing skills that were needed to be recovered during treatment. So this is really in all of our current services, so should not be a new thing for CPST providers moving forward. Next slide. So let's talk about the rate assumptions. So this, as I said, is not a comprehensive list of the rate assumptions that went into making the rates, but it is the majority of them and the most important ones. And so overhead was set at 15%. Supervisor to staff ratio is 1 supervisor to 9 staff. The absentee factor was 5%. Assumed staffing model includes a full-time clinical director, licensed or license eligible staff, QMHPs, behavioral techs, peers, and an administrative supervisor. So those are the staff that were assumed into the rate. Employee-related expenses, for full-time staff, it was 29%, and for part-time staff, it was 14%. Training costs were built into the rate. For a new licensed individual is $2,000. This is annually, $500 ongoing. For QMHPs and BH techs, a new individual, $800 for training and $620 ongoing. Accreditation costs were $10,000 for accreditation. Experienced staff to new staff, the turnover rate is 72% to 28%. Productivity was 6.5 hours of billing for center-based and 5.5 hours per day of billing for community. And the travel was set as 75 miles per day for community rates only. And the group size, as Lisa mentioned, was set at 1 staff person to 6 adult individuals and 1 staff person to 4 youth individuals. We can go to the next slide. So this is our draft service description, and I am just going to read it so everybody gets a flavor for what we're going for. Community psychiatric support and treatment is a multi-component team-based service for adults and youth that consists of assessment, psychotherapy, therapeutic interventions, care coordination, crisis support, and functional supports. In collaboration with the individual, CPST services concentrate on goal-directed supports and solution-focused interventions, which focus on restoring functional skills of daily living, building natural supports, and achieving identified person-centered goals and objectives as identified in the ISP. Individualized trauma-informed interventions are intended to assist the individual in achieving stability and functional improvement in daily living, family and interpersonal relationships, and personal recovery and resilience. CPST is delivered by 2 or more members of a team consisting of professional and paraprofessional staff offering a combination of trauma-informed, medically necessary community-based interventions. Services are provided through a team-based approach under collaborative behavioral health services as defined in the code. A licensed mental health professional completes assessments, develops individual service plans, and direct services provided by qualified team members as described in the ISP. So that is our current draft description. I'm sure it will be edited as we get public comment on our services. Next slide. So when we talk about the team-based approach of CPST, we'll get into a little more detail actually on the next slide. But on this slide, this really talks about the role of the clinical director or the fully licensed, independently licensed LMHP who is going to be supervising and providing some of the service components, including psychotherapy, assessment, and treatment planning. So this really discusses what type of LMHP oversight is going to be required. CPST providers shall have a full-time clinical director who is a licensed mental health professional and must be fully licensed in Virginia to practice independently. All CPST services shall be recommended and overseen by an independently licensed mental health professional as part of an ISP. All staff must provide services under the direct supervision of an LMHP. Supervision of staff and service provision must be provided by an LMHP employed by the DBHDS licensed CPST agency. And a senior level LMHP trained in working with individuals with serious mental illness or seriously emotionally disturbed youth is available to the staff 24 hours a day, 7 days a week for consultation on an as-needed basis. There are service components, as I said, that residents and supervisees can provide, but the service itself must be supervised and authorized and overseen by an independently licensed LMHP. Next slide. So when we talk about the team approach of CPST, this really is under the new code that was passed this year under collaborative behavioral health services through DHP regulation. So tier 1 must include a licensed mental health professional, as I said before, and may also include an additional LMHP or LMHP type or QMHP. So a typical tier 1 team, and when we talk about tier 1, we're talking about those individuals who may get maybe 4 to 8 hours of service a month. So this is going to be our new sort of less intensive service that we have not had in the past. As you all know, all of our CMHRS services are on really the more intensive acute continuum of our services. So a typical tier 1 team would look like an LMHP supervisor, an LMHP type who completes an assessment, does treatment planning, and provides psychotherapy and some crisis support most likely, and then a QMHP who provides restorative life skills training. So this would be the skill building part of the service. Tier 2 is going to be our more intensive service, and that's going to be on average, 20 to 28 hours per month. Must include an LMHP and an additional staff member who is eligible to provide Tier 1 services. In addition, Tier 2 may include a third team member. The team may include a QMHP trainee or the new professional that we will be having coming to our services called the Behavioral Health Technician, the BHT, to provide rehabilitative skills practice. The typical Tier 2 team includes a supervisor, an LMHP or LMHP type who completes an assessment, develops and directs the ISP, and provides psychotherapy and some crisis support. QMHP provides restorative life skills training, and a QMHPT or BHT who provides rehabilitative skills practice. So in general, a Tier 1 team is going to be 2 individuals, and in general, a Tier 2 team is going to be 3 individuals providing service. Care coordination and treatment collaboration with other staff or other individuals that work with the individual, including peer recovery support specialists and medication prescribers and other healthcare providers, is also required. You go to the next slide. This is just a visual of what we talked about in the last slide. So really what you're looking at is Tier 1, again, are the licensed individual and the qualified mental health professional. And these are the service components that each of those individuals would provide in Tier 1 service of CPST. And then for Tier 2, you're adding either a QMHP trainee or a behavioral health technician. And actually, I should have edited that slide to take out BHT trainees because we will not be using BHT trainees. So I'll need to edit that. We can go to the next slide. So we've already talked a little bit about this, but this is just who the staff, the service components that will be required, and then what staff can provide, are allowable to provide these services. So the standardized comprehensive assessment of needs and strengths will be conducted by the LMHP or the LMHP type. The QMHP can assist, but the LMHP or LMHP type is ultimately responsible. Treatment planning must be provided by the LMHP or LMHP type. Similar to the assessment, the QMHP can assist, but the LMHP is ultimately responsible for overseeing that treatment planning. Crisis support can be provided by LMHP, LMHP type, or a QMHP. Restorative life skills is the same as crisis support, so an LMHP, LMHP type, or QMHP. Care coordination is the same as restorative life skills, an LMHP, LMHP type, or QMHP. Psychotherapy can only be an LMHP or LMHP type, acting within the scope of their practice. Health literacy counseling can only be an LMHP or LMHP type. And rehabilitative skills practice, which is Tier 2 only, can be any, but mainly will be a QMHP trainee or behavioral health technician. Next slide. So let's talk about evidence-based practices, and we're going to have a lot more information coming out about this in the coming months, but we will be embedding evidence-based practices into Tier 1 and Tier 2 CPST, and they will be required for all agencies. The statewide training requirements will be set by professional level and adult versus child serving agencies. So all agencies will be trained in how to perform the standardized comprehensive assessment of needs and strengths. We are calling that CANS Lifetime, and associated person-centered treatment planning training. So all agencies providing CPST will be trained in those 2 items. For youth agencies, in addition, youth agencies must be trained in managing and adapting practice, what we call MAP. It is a treatment planning module, and it is modularized, and PracticeWise is a national purveyor of the MAP training. There will be needing to have at least 1 MAP clinician in each agency, and will be required for all child serving agencies. A Virginia-specific version of MAP training, which we are calling MAP Credential User, will be required for all staff providing CPST to youth. So there will be MAP clinician training and then MAP credentialed user training. We'll be getting more information to you guys about that very soon. But all youth agencies will have to have at least one MAP clinician and MAP credential user. All adult agencies, so all staff in those agencies, both licensed clinicians and all other unlicensed staff, will be required to complete a Virginia-specific training curriculum around how to best serve individuals with serious mental illness. Additional requirements and options for adult clinicians, in addition to the statewide curriculum, are still under development. So we are still working with DBHDS and our partners at the Center for Evidence-Based Partnerships to construct what that training is going to look like. So we're going to move on to Clubhouse International Model of Psychosocial Rehabilitation. This is a evidence-based program that is already in existence and is the national purveyor for that service is Clubhouse International. We are lucky to have one accredited clubhouse in the state of Virginia, which is run by Middle Peninsula Northern Neck, CSB. And we have been in contact with them and they have been wonderful to collaborate with. And we're looking forward to collaborating with all of our psychosocial rehabilitation programs to transition to this new service. Clubhouse is a community-based program organized to support adults living with serious mental illness. Clubhouse services assist individuals with behavioral health diagnoses to develop social networking, independent living, budgeting, self-care, and other skills that will assist them to live and integrate into the community. Participants are known as Clubhouse members. Through what is referred to as the work order day, the Clubhouse provides opportunities for member involvement and ownership in all areas of Clubhouse operation. Clubhouses are vibrant, dynamic communities where meaningful work opportunities drive the need for member participation, thereby creating an environment where empowerment, relationship building, skill development, and related competencies are gained. Members and staff work side by side in the program as colleagues. Comprehensive opportunities are provided within the Clubhouse, including supports and services related to employment, education, housing, community inclusion, wellness, community resources, advocacy, and recovery. In addition, members participate in the day-to-day decision-making and governance of the program. All of our new clubhouses must be accredited by Clubhouse International, and the policies around that are forthcoming. It typically takes, on average, 3 to 4 years to become accredited. And we will be working with the providers who want to become accredited clubhouses around implementation. Next slide. So these are the rate assumptions for Clubhouse. And again, these are not comprehensive. The group size was set at 1 staff person to 15 individuals. No less than 2 staff at all times when a client is or an individual is present at the Clubhouse. The Clubhouse hours are set to 8 hours per day, 5 days a week. And again, these are the rate assumptions, not necessarily what the hours are going to be for actual clubhouses. That's generally set in collaboration with Clubhouse International. Staffing, a shift is covered by a medical director, a clinical director, a program director, and Clubhouse International training and generalist staff. Again, these are just the rate assumptions that informed the rate, not necessarily what the required staffing will be for each clubhouse. Overhead was 15%, supplies 3%, absentee factor was 5%, employee-related expenses for full-time were 29%, and part-time staff 14%. The training costs per staff were $1,000 annually, and accreditation costs were $2,500. Experienced staff versus new staff turnover was 72% to 28%. Move on to the next slide. So we're going to move on to another evidence-based program that we're really excited to talk about. I think the community and DBHDS And a lot of advocates have been advocating for Medicaid to implement this service for many, many years. So we're really excited to say that we're going to be implementing it. It's a really exciting time. Coordinated specialty care for first episode psychosis, or CSC. I'm excited to say that DBHDS has been funding 11 CSC teams across Virginia for many years now. So we're excited to get to work with them and DBHDS to write our policies and really form what this service is going to look like on the Medicaid side. Coordinated specialty care is an evidence-based recovery-oriented team approach to treating first episode psychosis. Generally speaking, this is individuals who are in their late teens, early 20s, who have their first episode of psychosis. The service promotes easy access to care, shared decision-making among CSC team staff, the person experiencing psychosis, and the family members. First episode psychosis is generally regarded as an early period up to 5 years after the onset of psychotic symptoms. CSC provides comprehensive services that include, but are not limited, psychotherapy, evidence-based medication management, peer recovery support services, crisis supports, caregiver outreach and skill building, care coordination, case management, and supported employment and education. As I said, there are currently 11 teams, and we're excited to watch that grow as we implement on the Medicaid side. All teams will be required to participate in fidelity monitoring. And a plan for that will be worked out with DBHDS on how that's going to be done across the state with teams. It's going to be very similar to what occurs currently with assertive community treatment. Next slide. The rate assumptions for coordinated specialty care, the caseload assumption was 30 to 35 individuals. The staffing was 5.7 to 6.2 full-time staff members, 1 team lead, 1.5 to 2 lead clinicians, 1 full-time peer recovery support specialist, 1 full-time administrative support, 1 integrated treatment specialist, and 0.2 full-time of the psychiatrist's time. Overhead was set at 18%, absentee factor was set at 5%, employee-related expenses for full-time staff was 30%, part-time staff was 12%, and training costs per staff were set at $7,352. All right, so next is mental health case management. Again, we will not be retiring this service. We will be making some policy changes, but certainly the name and the procedure code will remain. So mental health case management is defined as a service to assist individuals eligible under the state plan who reside in a community setting in gaining access to needed medical, social, educational, and other services. Mental health case management includes the assessment, development of a person-centered individual service plan, referral to appropriate services, and monitoring of services provided pursuant to the ISP. Mental health case management, does not include the provision of direct clinical or treatment services. Excellent. So the rate assumptions, one of the new policies that will be implemented is a weighted caseload limit for case managers. For high acuity individuals, it'd be 20 individuals. For medium acuity, it'd be 40 individuals. And for low acuity, it will be 60 individuals. Supervisor to staff ratio is 1 to 9. The overhead was set at 18%. The absentee factor was 5%. Employee-related expenses was set at full-time staff 30%. Part-time staff, 14%. Transportation was set at 75 miles per day. Training costs were set at 8 days annually at $24 per full-time staff. And that is the end of the section around our services. Again, those are draft policies. As we move forward, we'll be getting the information out for informal and formal public comment, as well as working with several work groups to help inform our policy. Lisa, do you want to take over on provider readiness and survey training? providing a readiness survey and training?
Sure. Yeah, and feel free to jump in on it too, though. We can both do parts of this one. Thanks.
And you can hand it off to Heather for the DBHDS slide.
Yeah. All right. Well, so first things first, the way that we're really conceptualizing this is that this provider survey is going to be the first step in starting to communicate and collaborate with really, again, a number of you have been involved in answering surveys or answering our questions throughout the design process, but really at this point we're transitioning to implementation. And so, we have about a year now to get everyone up and running on the new services. And this is an optional survey, but we really urge you to treat it, almost like it's mandatory. And we'll talk a little bit more about what will be mandatory in the coming years to make sure that if you are planning to provide the service July 1 of next year, that you're at the table at the appropriate time and not that we're all kind of coming along together at the beginning. And so the first step really is this provider readiness survey. So again, this isn't informing any type of study for us. This is really for you to communicate to us that you plan to provide the new service. You don't have to be completely sure. It's okay if you're not. Obviously a lot of the details aren't out yet, but this is really the first way for you to communicate to us that you're interested in providing the new service. And it asks a number of questions about how ready you are to provide the new service. So for example, we know one of the big changes is going to be the requirement of the full-time licensed person as a full-time staff member, AKA the clinical director for each agency. And so this survey is that first line of communication between us so that we can get a handle on what agencies are already meeting that requirement, which agencies kind of can see a plan to meet it, whereas which agencies are interested in providing the service but don't yet have a plan in terms of how they'll meet that requirement. So this is really your way to start communicating your needs to us. You can see the QR code there. It's a Microsoft form, and we are asking that you complete it in the next 3 weeks. Again, it's okay if you don't have a perfect answer to each piece of it, but the sooner that we start kind of communicating back and forth on this, the better. And so, yeah, the due date that we have is, what is that, August 8th?
August 8th. It closes on August 8th and we'll go live today at 12 p.m. So if you click on the link or type in the link, it'll just say it's not yet live, but it'll go live at 12 p.m. today.
Thanks, Laura. Next slide. So this is, again, sort of a high-level timeline of just the provider readiness components of the year 2 plan. So like we just said, this survey, there's no sort of way for us to require something like this, but so we are strongly recommending this. Again, this is how we are going to use our budget to pay for the statewide trainings. You heard from Laura that the cost of trainings is written into the rates, so that providers will have the revenue from the services to pay for ongoing training from a sustainability perspective. But we know that these rates are not going live this year, they're going live next year. And so DMAS and DBHDS, everyone is doing everything we can to pool resources at this time so that we can contribute in any way possible to having providers ready to go July 1. And so if we don't know how many staff you have that are going to need to be trained on the adult and the youth curriculum, it's going to be very hard for us to enter into contracts with these training entities to make all this come together. So again, we are strongly recommending that you complete this survey. The next piece that we wanted to highlight, again, there's a lot about the year 2 plan that's not exactly nailed down. We're really wanting to focus on opening up bi-directional communication to make it all work. So biweekly office hours is something that we want to start in September. So essentially this will be only 4 providers that are kind of on this path hoping to provide the service. So these will be direct open office hours with DMAS and hopefully DBHDS staff. If we need to invite DHP, again, this is just our time to have folks on the line to hear about questions that people have and things like that, and just keep communication open. The plan is that we will hold those once a week, every other Friday. Again, we won't be able to address every question directly, but that will be our time to do, pulse check, temperature check, see how everything's going and hear directly from the providers. Heather, do you want to share a little bit more about how the letter of intents typically work for DBHDS? We have October as the draft date there. Oh, you're on mute, I think.
Thank you, Lisa. Yes. So what we're going to need to know, and to make sure that everybody, of course, is licensed in a timely fashion, is the services that providers will be interested in providing, as well as, tiers, etc., location across the Commonwealth. We're currently working with the team to be prepared for the transition for providers, to make sure that everybody has the correct licenses come July 1. So we will need to have that information in order to make sure that we can make a schedule, make sure that everybody gets reviewed, gets seen, and has all the things that are needed to be done. And that's, and I'm just going to reiterate something that Laura and Lisa said, which is why it is extremely important that you complete the survey, because that will also provide information for what we're preparing for and the work that needs to happen.
Yeah, I think from here on out, it's kind of tag team. I don't know. So I'll give a little bit, and then Heather, if you want to just kind of take on anything else you want to add on this slide, because as you can see, the next pieces are these training opportunities. DBHDS as the state mental health authority, they're going to be running a lot of this. Obviously, we're going to be contributing everything we can as well. Also, our health plan partners are going to be, they're provide training and are contractually obligated to do so. And so we're trying to coordinate really anywhere where we can to pull all the pieces together. But high level, the idea is that the training opportunities will run approximately during the 2026 calendar year. So the 6 months prior to go live and the 6 months after go live is when you'll see a lot of those state sponsored opportunities. And then sort of obviously in between there will be a bar set in terms of what specifically is required for that, initial go live. We do some training will be still going on in those 6 months after go live. And, we'll be balancing those two things to make sure that everyone is ready to go live, and also that we do have statewide coverage, that we have providers that are licensed and ready to go. And then, long term, we'll move into more of a monitoring quality improvement way. We're kind of thinking about 18 to 24 months after go live is when some of that will be formed up. For example, with accreditation requirements, you have to be providing the service for at least 18 months before you can get accredited. So that's about the time frame where we'll be moving into like a more fully stable, hey, this is what the service looks like. That's really, up to about 2 years after go live. So this, even though it feels like we've done a lot to get to this point, there is still a whole year before go live, and then really 1 to 2 years after go live, where this is all going to be a very active project. So I think I'll pass. Anything else you want to add on this slide, Heather? And then I believe that there's another slide next.
Yeah, I'm going to go ahead to the next slide, because what I would have added to that slide is actually also on this slide, which is obviously we have been working side by side with DMAS around redesign and the new services, and we are drafting the regulatory amendments around CPST. We also are starting Clubhouse and CS, Coordinated Specialty Care, CSC, as well. Our goal for CPST is to have that approved by September, and we'll be working with the board around Clubhouse and CSC before December. I think it's important to know that in addition to the training that we'll be doing in order to implement CPST, we'll also be providing training and education around changes to licensing process, submitting the application, all of that information. Again, it is why completion of the survey, letters of intent, is going to be so critical to make sure that all these things happen, because our team is in the process of developing application review standards and processes. We will be putting together various communication about when you need to do the different things and the status of the changes. And then, of course, in order to be prepared for a go live of July 1, we have to start issuing those new licenses effective prior to July 1. So we'll be working very quickly over the next couple months to put together that timeline and that schedule. And then, of course, we will get that information out to stakeholders so that everybody is aware.
I'll take over on this one. So this is the last slide of our presentation about next steps. I want to encourage folks to use the Microsoft Q&A form that is live right now. You should have gotten the email from me, hopefully with the link and the link at the beginning of the presentation to submit your questions. And we will be using those questions to develop an FAQ that we will put on our website. I also want to encourage everyone to go on our DMAS homepage where you can sign up to get communications from DMAS. This is really often how we send out information. You would have gotten an email, everybody got an email, several emails, corrective emails about this webinar because the registration link didn't work at first. I apologize for that inconvenience to you all. But that's really the best way to get information from us is to sign up on our public website. So next steps for all of us, but really our provider community, are to determine what services you tentatively want to seek to offer. We really encourage you to complete the provider readiness survey to share your plans and to provide us with contact information for all of the next steps. Be on the lookout for managing and adapting practice therapist training that will be offered by DBHDS and the VCU Center for Evidence-Based Partnerships. MAP Direct Services training will be offered in early fall. CANS, our assessment training, and MAP Qualified User and Adult Rehabilitative Training opportunities will be publicized by early fall, and training will be offered January to December of next year. As Lisa said, we're going to be having provider office hours. Those will start running in September and run through July of next year. And we'll be getting that information out to you all via signing up for how to get information from DMAS. So make sure you guys sign up on our homepage for that. And then we'll be coming up with a plan for how to support providers after go live. And we'll be getting information to you all out about that closer to go live. But the office hours are really one of the most important things, and we'll get information out to you guys as soon as those are scheduled. And you can go to the next slide, Heather. That is the last slide of our presentation. Is there anything else you all want to say before we close out?
No, just thank you everybody so much for coming. We know this is a lot of information, but we wanted to sort of share with you everything that we know at this point. We'll be doing our best to get this information out in many different formats, you know, everything Laura mentioned on the website and the slide deck, so that we can, you know, all come together to get year 2 of this project going. So thank you so much for coming. Heather?
Yep. Thank you all. I appreciate it and hope everybody has a great rest of the week.